Distalization. What I use is a modified pendulum that we published in the JCO in 2003 with 4 removable springs. First, we distalize the second molar, then we distalize the first molar, and then using sectional wires and the microimplant to maintain the anchorage, we distalize the bicuspids and the other teeth. This is very important because distalization is very easy, but maintain the position of the molar after the distalization is very difficult, so microimplant works very well. So this is the complete protocol that we use, and this is a case with the first class in the right side and second class in the left side. Initial records, and I take out this wisdom teeth, the upper left, and then we have the pendulum with tubes and removable springs. This is activate the first and then activate the second spring for the first molar, making the distalization of the both. And as the springs are removable, we can control everything. And also we can check the inclination of the molars with X-rays and correct this position. To activate this spring, we activate following the dental line. This is distalization. To avoid the mesial rotation of the molar, we include toeing. To avoid the inclination of distal inclination of the crown, we do reverse tip back, and also to avoid the clockwise rotation of the mandible, we active intrusion. So after the distalization of the molar, we insert a microimplant measurably to the molar. Anesthesia and mucosa measurement, using the scalpel to separate the soft tissues, and then inserting the microimplant. X-ray control, and then using a sectional wire and elastic change, we distalize the bicuspids and then complete the case as you can see, near to the end of treatment and finishing the case. At the end of the treatment, with a good inclination of the molar, final records, superimposition of the cephalometric tracing, and then what we can do now is to reinforce the anchorage of the pendulum by making 2 holes in the pendulum and inserting microimplant through these holes. In this way, we can avoid completely the possible protrusion of the incisors. Then we distalize first the second molar, then we distalize the first molar, and then, maintaining the pendulum, we can distalize the second bicuspid and also the first bicuspid. And we can maintain these springs, these blue springs, to retract the incisors with the 8-finger ligature from cuspid to cuspid. So this is a case of a second class, but also with impacted cuspid, upper left impacted cuspid, here, and then we can bond the brackets, we can open the crown of the cuspid, and then bond a pendulum and insert the microimplant through the acrylic part of the pendulum, beginning with the latch lock driver and finishing with the thumb wheel in both sides. Here we have the impacted cuspid and also all the wires of the pendulum and also the microimplant. And here is the progress of treatment. Pendulum reinforced with microimplants. Opening the space for the cuspid by distalizing the molars in the left side. And also, with the same appliance, we make a loop here to pull the impacted cuspids. So you can do a lot of work with a resin plate fixed to the palatal area with 2 microimplants. And we can see distalization and also the movement of the upper cuspid. Also for distalization, we can use a microimplant with a sliding tube, distalizing coil spring, and a wire ligature. And this is the way. We insert a microimplant, especially in the area of the alveolar zygomatic crest, and not in between the root of the teeth, but as parallel as we can in order to facilitate the molar movement to distal direction. These are the coil springs, and this is a sliding tube. It is not welded to the wire. But now what we use is a tube with a long hook to avoid the intrusion of the bicuspids. This is a case with first class in the right side and second class in the left side. So, brackets, the sliding tube, the coil spring, and inserting the microimplant, anesthesia, and mucosa thickness measure. Here is the separation of the soft tissues with the scalpel and insertion of the microimplant. Parallel to the root and not in between the root. And then we activate the coil spring by using a wire ligature from the sliding tube to the microimplant. And this is the progress of treatment. You can see the spaces here. But now we use a tube with a long hook to avoid this intrusion. In this case, I had to use intermaxillary elastic to avoid the intrusion of these teeth. Spaces opening because of the distalization. Progress of the treatment. Correcting the midline, but these elastics are to control this intrusion. Progress of the treatment. And close to the end of the treatment again. And now finishing the case. One year later, also we can distalize molars directly from the microimplant, as shown in this example, in this scheme. And this is a case with deviation of the midline, crowding and rotation, and not enough anchorage for the distalization. This molar don't offer enough anchorage for this distalization. That's the reason why I inserted one microimplant in this area, disinfection, anesthesia, mucosa thickness measurement, separation of the soft tissues with the scalpel, and insertion with the ratchet and with the thumb wheel. Checking the stability of the microimplant, and the microimplant seems to be inside the sinus, but it is more labially positioned. So with a wire ligature, we can distalize both bicuspid at the same time, and with differential forces we can also correct the rotation. So, progress of the treatment. And here we are close to finish the alignment and the rotation control of the teeth without protrusion, and correcting also the midline. So we went from here to here, very, very easy, only with the support of a microimplant. X-ray control, and now you can see here alignment and leveling as well as midline correction. Before and after in the upper jaw, but finishing the treatment in the lower